Good evening. I try and do this every week. How many people have been to these these before? Oh, good. How many people have been more than one? I do see some faces that I recognize. Great, fantastic. So, welcome back again. Tonight, our session is why paying physicians and hospitals for their performance scares them. So tonight we have two speakers who I think we're really lucky to have them, and I'm going to talk about them a little bit now. Gary Young is our first speaker. Gary he's a colleague, first of all, who works in the business school with me. He's the director of the Northeastern University Center for Health Policy and Healthcare Research. He's also a professor of strategic management and healthcare systems at Northeastern University. He's affiliated with the Health Services Research and Development Service of the Department of Veterans Affairs as well. Before joining Northeastern, Gary was chairman of the Department of Health Policy and Management at the Boston University School of Public Health. He's worked as a healthcare attorney and analyst within the federal government. He's worked for a national healthcare consulting firm, and his research focuses on the organizational, managerial, and legal issues associated with the delivery of healthcare services. He's received research funding from government agencies and private foundations. Some of them include National Science Foundation, Robert Wood Johnson Foundation. His works appeared in a whole variety of really good journals, New England Journal of Medicine, JAMA, Journal of American Medical Association. He's won several awards. He's the recipient of an Investigator Award in Health Policy Research from the Robert Wood Johnson Foundation for his work on the application of pay for performance to the U.S. healthcare industry, which makes him an expert on this topic, and you'll see in a moment what I mean by that. In 2012, he was appointed by the U.S. Secretary of the Treasury to the Internal Revenue Services Advisory Committee on Tax-Exempt and Governmental Entities. That's a mouthful. One of several congressionally mandated committees that advise IRS officials on policy and procedural issues. And he is not only a PhD, but he's a lawyer. And he received his law degree and PhD in management both from the State University of New York at Buffalo. So he will be our first speaker. Our second speaker, who we are also very lucky to have tonight, is Sarah Islin. Sarah, and she's right down here. Sarah is Senior Vice President for Strategy, Policy, and Community Partnerships with Blue Cross Blue Shield of Massachusetts, and she is also their Chief Strategy Officer. She is responsible for the company's strategic services, including internal business consulting and strategic and business planning. She leads the company's corporate citizenship team as well. From 2010 to 2012, Sarah was the president of the Blue Cross Blue Shield of Massachusetts Foundation, which is one of the largest private health philanthropies in Massachusetts. And she came to the foundation after serving as the commissioner of the Massachusetts Division of Healthcare Finance and Policy, where she managed and monitored critical phases of the implementation of the state's landmark 2006 healthcare reform law, including the formation of the health safety net and of the fair share, free rider, and health insurance responsibility disclosure requirements for employers. She's co-chaired the Special Commission on the Healthcare Payment System, which was a group that recommended a major overhaul in the way physicians and hospitals are paid. Prior to her appointment as commissioner, Sarah worked on the development of statewide quality and safety initiatives for Blue Cross Blue Shield Massachusetts. From 2001 to 2005, she was the director of policy and research for Blue Cross Blue Shield Foundation, where she played a key role in developing the foundation's roadmap to coverage initiative, which provided the framework for the state's 2006 health reform law. And she has a master's in health policy management from the Harvard School of Public Health. And as you'll hear, given all the things that Blue Cross Blue Shield, I think, is considered one of the forerunners, certainly in terms of how they're trying to attempt payment reform and innovate to provide improved quality of care for their covered individuals. So we'll start first with Gary. He'll present for about 40 minutes, and then we'll move on to Sarah. We'll take a little break, and then we'll have some Q&A. So, Gary.
Thanks. Good evening. How do I
Space bar. So, sort of begin, as consumers, we're all used to going out and buying things, cars, televisions, washing machines, and I think it's fair to say that when we all go out and buy things, we tend to think of value, right? Sort of a cost-quality relationship. That's sort of our driving principle of being a consumer, right? We want to make sure we're getting good value for our money. Well, healthcare really hasn't worked like that at all. Okay? And so what I'm going to talk to you a little about is sort of how we've actually paid for healthcare services in this country. The sort of transition that we're making now to sort of move away from sort of the old style way of paying for healthcare services and moving in the direction of value, like so many of our other consumer purchases, to think about purchasing healthcare the way we do a washing machine or a TV or a car. Okay? To think about it in terms of value. All right? I'll talk to you a little about what some of the evidence is about how well this is working. Okay? And then, I know the theme is today is, should we be scared about this? And we can talk about whether we should be scared about it. Okay? And I know Halloween's around the corner, so I'll keep that in mind. So how do we pay for healthcare services in this country? How do health plans, employer groups, government agencies, Medicare pay for healthcare? Well, the predominant approach to paying for healthcare is something that we call fee-for-service. It means you go to your physician, there's an office visit, the physician is paid for the office visit. You have a procedure done, okay, in the hospital, outside the hospital, there's a fee that's paid to the person who performs the procedure, or a fee paid to the hospital for performing the procedure. Okay? Fee for service is largely the way we've always paid for healthcare services in this country. Okay? Now, we have tried some other things. Certainly a watershed event in the 1980s, early 1980s, was this concept of diagnostic-related groups, which is how Medicare pays for hospital care, okay? Where we've taken services and sort of bundled them up. Okay, individual services and bundled them up into a larger diagnostic category, like appendectomy. Okay? And then hospitals through Medicare receive a fixed amount of money for providing that appendectomy. And that's all they get. They get a fixed amount. If the hospital's costs go over that fixed amount, they lose money. If they provide the service, the appendectomy in this case, for less than the fixed amount, they make some money. So we've tried that, and that's still in play. We also, in the 1990s, experimented with this concept of capitation, where actually healthcare providers, often primary care physicians and large physician group practices, would be paid a fixed budget in advance of providing any services at all. They'd be provided a fixed amount of money for taking care of an individual for a 12-month period. And they would be responsible for a certain set of services. It could be primary care services, some specialty services, in some cases even what we might call global capitation, where they're largely responsible for all services. But they'd be receiving the amount, they'd be receiving their reimbursement, their payment in advance of actually providing any services. Okay? Which presumably provided some incentive to try to control costs. Right? Capitation. Now, what's missing from all of that, of course, is I haven't said anything about quality. Okay? Nothing about, talked about value, cost, quality, trade-off. I've been talking about payment, and I haven't said anything about quality. Where does quality figure in? Well, so now we're moving on to something called pay for performance, where we're actually trying to link a provider's payment in some form to the quality that they actually provide. Okay? And even more so now moving to something called value-based purchasing through global payment arrangements, which really, I'll talk more about this in a few minutes, is really sort of a combination of capitation and pay for performance, where we provide providers that kind of budget, okay, but then we also sort of superimpose on that a variety of quality targets that we ask them to achieve as well. So, why are we moving in this direction? Okay. Well, for one thing, we've learned over the last 10 to 15 years the quality of care in this country actually isn't particularly good. I know we all think of the U.S. as providing excellent quality of care, and in some cases that's true. But actually the evidence would suggest that quality of care is actually suboptimal in this country. Okay? Sort of a major event in that direction occurred in the late 1990s when the Institute of Medicine released a report that said that between 50 and 100,000 people die in this country every year due to medical errors. That was followed by another very important sort of landmark study by the RAND Corporation, which obtained medical charts, large sample medical charts for patients all over the country, looking to see how care was provided relative to the best scientific evidence, And the conclusion of that study was that we only receive the care we should receive. We only receive the care that we should receive half the time. Okay? We only receive the care that we should receive in terms of the best scientific evidence available half the time. So when you go to your provider, you go to your physician, you're really sort of flipping a coin. You might get the care you're supposed to receive, and you might not. You're flipping a coin. So, and then a number of other studies that followed up on that also demonstrated quite convincingly that, again, care in this country is suboptimal. Providers aren't often providing the best care that they could provide in terms of what's available, in terms of the best scientific evidence. The other thing is escalating costs. Okay? Now, in the last couple of years, costs have actually begun to sort of moderate a bit, but over the last 10 to 15 years, we've seen really rampant healthcare cost inflation in this country, okay, actually stretching back longer than that. And the idea is, how are we going to control costs? Well, one idea is if we keep people healthier, if we improve quality of care, that may be one way to, in fact, control costs, to keep people healthier so that they don't need high, expensive services, so-called business case for quality. So, along those lines, I mentioned before fee-for-service. So what is the kind of incentive that fee-for-service creates? Well, it creates an incentive to provide more services, greater volume, because every time a service is provided by a physician, a hospital, okay, you're sort of hitting that cash register. There's more money coming into that provider. Okay, it creates that kind of incentive. Again, no link to quality, just an incentive to provide more, higher volume. And over time, this has really been our experience. Okay, since 2000, health insurance premiums have pretty much doubled. Okay. Most people receive their health insurance through their employer. And workers' contribution to their premiums have also pretty much doubled. Okay. But earnings, inflation, much lower rate. Much lower rate over the last 12 years. So we've had a payment system in place that's really driven healthcare costs at a very fast rate, much faster than inflation, and certainly much faster than earnings. And again, where is quality in that equation? Well, there's many different ways of presenting that, but here, when we look at what we actually spend per person, okay, relative to our life expectancy, we kind of stick out. All right, kind of stick out. We spend a lot more than a lot of other countries, and our life expectancy is just sort of in the middle there. All right, now there's many factors that influence life expectancy. Many factors: diet, exercise. All right? But one could look at that and say, well, where really is the return on investment there? We're spending a lot more per person than many other countries, or virtually all other countries. But in terms of health status, we may not be getting a big return on our investment. Okay. So what actually is pay for performance? What do we really mean by that? What is pay for performance? Well, one thing involves a financial incentive. Okay, some sort of financial incentive. Now that may be in the form of a bonus for achieving a quality target. It may entail a tournament where providers are competing each year to achieve the highest level of quality on some sort of measure. And those that achieve the highest levels receive more money than those that do not do as well in relative terms. Okay? It may entail an adjustment of a fee schedule. But the idea is it involves some sort of financial incentive. Some sort of financial incentive that's tied to a performance target. And that can be a quality target, such as the example here. Your provider has patients who have diabetes. And so they're supposed to make sure those patients receive an annual blood sugar test each year, so-called hemoglobin A1C test, a blood sugar test each year, which is considered to be very important for managing the care of a patient with diabetes. It can also entail an efficiency measure. Okay, so it can be quality, it can be efficiency, it can be both. All right? And of course, there has to be a target recipient, some unit of accountability. Who's responsible? Who's responsible for achieving that performance target and ultimately receiving the financial incentive? Well, that can be an individual physician. It can be a physician organization. It can be a hospital. It can be a team of providers. Okay? For the most part, we've experimented with pay for performance for individual physicians and physician organizations and hospitals, but we're increasingly thinking about creating incentives for teams, or integrated arrangements of providers, which I'll talk a little more about in a few minutes, a so-called accountable care organization. But these are the basic elements, 3 elements: a financial incentive, a performance target, okay, and some target recipient, some unit of accountability that's responsible for achieving that performance target. And really, pay for performance has become a centerpiece of U.S. healthcare policy right now. Okay, I don't think that's an exaggeration in any way. It's really become a centerpiece of U.S. healthcare policy. Why? Well, on the private sector, there's well more than 200 pay-for-performance programs that exist at the level of health plans, employer groups. Over half the state Medicaid agencies now have pay-for-performance programs in place. And the Accountable Care Act, okay, what some people are referring to as Obamacare. Okay, we've all heard a lot about Obamacare in the last few weeks. All right? That has several key provisions that really promote pay for performance, or what's referred to in the law as value-based purchasing. Value-based purchasing. All right? And there's 2 major provisions. Okay? One that creates pay for performance programs for specific types of healthcare providers like hospitals and physicians and nursing homes. And another provision that creates value-based purchasing for ACOs, accountable care organizations. A shared savings program that involves sort of a global payment structure, which I'll talk about. Okay? ACOs are typically provider organizations, usually more than just one type of provider, physicians and hospitals coming together that assume clinical and financial responsibility for caring for individuals under their responsibility. Okay? Assigned individuals that are assigned to them. Okay? And they assume both clinical and financial responsibility for the care of those individuals. So in terms of the provider-specific pay-for-performance programs the ACA creates, the law requires implementation of value-based purchasing of these pay-for-performance programs for hospitals. That's already in play. Last October, that was rolled out. So hospitals are now participating. For those hospitals that participate in Medicare, they are now already involved in a value-based purchasing program. In 2015, physicians get folded in. Okay? And the law also requires planning of pay for performance for other types of healthcare organizations as well, other types of healthcare providers. Okay? So the ACA very much promotes the concept of pay for performance through the Medicare program, our largest purchaser of healthcare services in this country. Okay? Medicare, which covers individuals over the age of 65 and over, and also certain other individuals, such as those that have end-stage renal disease. So just looking at what's already in play for hospitals, so hospitals, as I mentioned, that already began last year, October 2012. Okay, it is a budget-neutral program. Okay? Budget-neutral, which means the government, in principle, isn't spending any more money to have this program than it would otherwise. Okay? And the way that's done, as I mentioned, DRG payments is the way the government pays hospitals. That fixed amount that's linked to a particular condition, like appendectomy. Okay? 1% of hospitals' DRG payments are swept away and put into a pool. And then hospitals compete for that money. And it's set up so that some hospitals actually end up making more than they would have made in the absence of this pay-for-performance program, and other hospitals take a haircut. They make less. They're competing. It's about $850 million involved. That will transition from 1% to eventually 2% in 2017, okay, where the stakes get a little higher. Maybe not dramatically so, but they get higher. And certainly for some hospitals, most hospitals in this country operate on pretty narrow operating margins, 2-3%. And so this is real money to most hospitals. Hospitals, in order to compete for that pool of money, are asked to achieve certain performance on clinical process measures, eventually, and patient experience measures. Eventually, they'll be asked to achieve patient outcome measures and also efficiency measures. And what do those look like? Well, here are some examples. So for clinical process, we have prophylactic antibiotics for surgical patients within 1 hour of surgery. Okay? So there's a certain benchmark that they're asked to achieve. Okay? The percentage of their patients that actually, for which they meet that particular performance measure. Okay? Discharge instructions for patients with heart failure. Okay? As I mentioned, next year in 2014, they'll also be assessed on the basis of clinical outcome measures, mortality for heart attack, heart failure. And then they're also currently being evaluated on the basis of patient experience measures, which are surveys that go out to patients, sort of 1 to 5 kinds of scales that most of us have experience with, where people are rating their experience on a variety of dimensions like communication, emotional support, communication around medications. Okay? And those scores also factor into how well a hospital does in terms of being able to access this pool of incentive money. Okay? And actually, hospitals are scored not just on how well they do in absolute terms, but also in terms of whether they improve. So they actually receive points both for improvement and also achievement. So, you know, the hospital's performance on these measures determine how much of that DRG payment they actually get back, that 1% that's actually taken out. So I mentioned another key provision is this accountable care organization shared savings program. All right? And so that's where providers come together, hospitals, physicians. The idea is to provide integrated care, okay? And they assume financial and clinical responsibility for managing the care of Medicare beneficiaries. And there's a certain budget that's established, and if they achieve a certain level of savings, okay, they share in that savings. In addition to that, there are a number of performance measures, performance-related quality measures, that they're also asked to achieve, some of which are very much focused on population health, like influenza immunization, colorectal cancer screening. So there's both an incentive to reduce the cost of healthcare services over time, as well as an incentive to improve quality of care. Okay? Trying to get closer to that idea of value. This is what's going on right now in Medicare. In the private sector, we're also seeing some similar programs. Similar programs to this ACO shared savings program. The most famous of which is Blue Cross Blue Shield of Massachusetts Alternative Quality Contract. I won't say much about it because we've got someone here who's far more expert in it than I am. But Sarah will also talk about what has really become a benchmark for the rest of the industry. Okay, everyone is looking at this alternative quality contract program, which again looks a lot like the Medicare shared savings program. But this is something that now exists in the private sector, and there are many people around the country thinking this is the way we'll go everywhere in the country. Okay? We'll have these integrated provider organizations operating under a sort of fixed budget for care where there's an incentive, or shared savings, and where there's also quality performance targets, which result in additional dollars to the provider organization. So, I think of sort of what goes on in youth sports as sort of an interesting metaphor. All right, I know. So why is he showing this, right? But let me see if I can draw a connection here, because I saw a connection anyways. So, for those of you that have had some experience with youth sports, last 10 or 15 years, you know that there's really been a sort of a sentiment that when the kids are really young, we shouldn't keep score. Okay, everybody gets to say, so everybody's sort of, I see a lot of people grimacing actually, but okay, so. But the idea is when they're really young, we don't keep score, everybody gets the same size trophy, all right? That was, when I coached my son's hockey team for years, that was always the experience when the kids were real young, you just didn't keep score and everybody got the same size trophy at the end of the year, okay? It didn't, actually, it doesn't always work well because I'm sure you always know there's always one kid, right, on the team who's blurting out the score, right? That was my kid. But you try anyways. That the idea is you don't want to sort of expose kids early on to sort of the pressures of competition. I mean, that's the philosophy behind it. All right? But that is the point. So when the kids are young, you don't keep score, and you give everyone the same size trophy. Well, in fact, that's what we've been doing in healthcare forever, because we didn't keep score of how well providers were doing, and we gave them all the same size trophies. But that's changing because now we are keeping score. Okay? We are keeping score, and we're giving out different size trophies. Are providers scared? Right? That's sort of our theme today. Should we be scared about this? Are providers scared? Okay. Well, there's been a lot of surveys of providers about how they feel about pay for performance and value-based purchasing. We've done a number of surveys ourselves. In fact, we've done 2 statewide surveys in Massachusetts and California. Okay. Representative samples of physicians. These are states where there's been a lot of activity around pay for performance in the private sector. All right. And our survey results actually look a lot like other people's survey results. Okay, which is that, actually providers don't seem terribly scared or upset about this, all right? When you ask them questions like, should you be rewarded, for providing higher quality of care, both states, you see physicians responding with sort of a, yeah. Okay, there's sort of a general agreement about that. There's no evidence that they're really frightened about this or have, at least in principle, are opposed to the concept of pay for performance of value-based purchasing. Now, whether or not they think it's really going to work and improve quality of care, well, there, you see a little bit more ambivalence. Okay, you see a little bit more ambivalence. Do they really believe it's going to work? Do they really believe it's going to improve quality of care? But I don't think they're necessarily scared about it. Should you be scared? Is there any reason for you to be scared about pay for performance? Well, there's a couple of considerations I think that, are important to know. One is it even going to work? All right. As I said, this has now become a centerpiece of U.S. healthcare policy. We are investing a lot of resources in this, both intellectually and financially. Okay? This is sort of where the seed corn is going. All right? We are investing a lot of money in developing pay-for-performance or value-based purchasing infrastructure. Okay? Will it work? Okay? That's something to possibly be a little anxious about. All right? And the other is unintended consequences. Could there be some unintended consequences from all of this? Some things that we haven't necessarily foreseen here that's going to come back and bite us. All right? So let me talk about each one in turn. All right? Well, I would say that right now the evidence on pay for performance, because there have been a number of studies that have been done over the last 10 years since pay for performance, sort of the early, particularly some of the early pay for performance initiatives that were conducted. I will say that the evidence isn't all that bright. Okay? We usually see modest gains in quality. When you give providers financial incentives to achieve quality targets, okay, like making sure that their diabetic patients receive a blood sugar test, or making sure, or trying to make sure that providers are promoting mammographies for women over the age of 50, you do see some gains, but they tend to be modest, not dramatic. Okay? Now, actually, some of the more impressive results, for Sarah on this, are coming out of sort of the alternative quality contract Blue Cross Blue Shield's program. Okay? Although I would say it's still early on. That's a fairly new program. All right? But we just don't see dramatic gains. All right? And I'll show you some data just from my own studies, but I think the data that I'm going to show you really are very consistent with a lot of other studies that have been done. So here's a study that we did a number of years ago, one of the early pay-for-performance programs that was conducted out in upstate New York, Blue Cross Blue Shield, and a large physician network. Okay? And they created a program to improve quality of care for patients with diabetes. They incentivized primary care physicians around 4 measures. One is hemoglobin A1C, that's the blood sugar test that I keep referring to. Making sure that patients have an annual urinalysis, have their cholesterol levels checked, and a retinal exam. Patients with diabetics, of course, are elevated risk for blindness, and so that's considered to be a very important initiative to undertake. And really all of these are very well supported by the best scientific evidence available. These are measures that really reflect the state of the science. So this is what should be done. All right? And so in 1999, that was baseline data. They actually introduced the financial incentive to physicians. Okay? They gave them it was a really sort of what they would call a tournament-style program, where they gave physicians the amount of money that they could receive, which was up to about $7,000 or $8,000, depending on their relative ranking in terms of how well they scored on these measures. The higher the percentage of the patients that they had who had these screens and tests, the more money they could make. Okay? And as you can see, adherence to those measures is not particularly great in 1999. They really should be all 100% in principle, and they're nowhere near that. Okay? Then we jump to 2004. That's 2 years after physicians were given a financial incentive, okay, to make sure that patients receive these tests and screens. Okay? You see the numbers go up. And you might say, well, that's kind of impressive. That's good. Okay? Certainly better than where they were in 1999. The problem is that when you look at it in terms of actual trends, you often see something that looks like this, which is a lot less impressive, right? Because it looks like they were all going up anyways for the most part. They were just sort of going up over time. So if you just look at it in terms of 2 data points, you get sort of a distorted picture of what's really happening here. Now, in fact, the only one that did really seem to increase at one point in time was the retinal eye exam. That's the red line, the one on the bottom, which actually had the lowest baseline value as well. Okay. And it did go up at one point, and then it sort of returned to its previous sort of rate of improvement. Okay, so you sort of got a one-time bump up there. But that was about it. And in fact, when you look at a lot of other studies, you see something very consistent with that. You see these maybe sometimes modest gains for 1 or 2 of the measures at one point in time, okay? But you don't necessarily see, continuous improvement over time. So the gains have been modest. And there isn't necessarily a lot of evidence, okay, to really sort of galvanize us around pay-for-performance, value-based purchasing, where we can really say we're extremely confident this is going to work. Well, if that's true, what are the barriers? How come it's not working as much as we would hope it would work? What's sort of impeding our progress here? I mean, it sounds right in principle. We should be paying healthcare providers in ways that relate to the quality of care they provide. We should be thinking about value. That's how we buy our TVs. That's how we buy our cars. We should be thinking about value. Right? So what are the barriers? Well, there's a number of barriers. One is that we're sort of assuming that money will work as an effective motivator. It will get providers to do better. Okay? There's actually a lot of evidence, a lot of theory, a lot of literature that would suggest that, well, money may not always be an effective motivator. For one thing, we know that providers value their autonomy. We're sort of creating or imposing some controls now on how they do things. We're sort of telling them sort of how they should spend their time, how they should focus their efforts. Okay? Providers may think about certain trade-offs in terms of their own autonomy and the monetary incentives that are available to them. They may not all see it in the same way. Providers may vary in terms of how they think about that trade-off between their own autonomy and payment incentives. Okay? So, just to go back and showed you that a minute ago, and again, as I said, really, the one that only really improved was the retinal eye exam. Okay? But at the time that this program was rolled out, okay, just before it was rolled out in 2002, okay, we also surveyed the physicians that were participating in this program. And we asked them about whether they had any concerns about whether this program would in fact sort of undermine their autonomy, their clinical autonomy. We asked them about whether they had any real concerns about whether the health plan, was sort of cutting in on sort of their turf. Okay? We also asked them about what they thought about these clinical performance measures they were being asked to achieve. Okay? So we surveyed them and we got that information, and then we were able to sort of follow up over time to see whether there were any differences in terms of how physicians responded to that survey and their actual performance. And this is what we found. Okay? Each of those measures that I told you about, they all follow the same pattern. Okay? And here what we've done is we've divided physicians up in terms of whether the blue line indicates physicians who didn't see any real concern about their autonomy being undercut. Okay? And the ones in the pink, the pink line represents those physicians who were concerned. But what you see is a tale of two physicians. Those physicians that were not concerned about autonomy actually did respond to the financial incentive. Those that had concerns did not. Okay? And so when you combine them together, you don't see much improvement. Okay? But when you sort of unmask that variation, okay, in fact, you've got two groups there. One that did respond and one that didn't. They cancel each other out. Same thing in terms of how they felt about the clinical goals and how important they were for their patients. Okay? Same pattern. So that's a potential barrier. Okay? Another barrier is that once we begin to monetize quality of care, assign a price to it, okay, we really don't know what's going to happen. All right? Once you assign a price, once you begin to monetize something, you begin to change the character of that activity. We already believe, I think most of us do, that physicians to some degree, go into medicine because they have sort of an intrinsic motivation to provide high quality of care to begin with. And now we're assigning a price to it. We're monetizing quality. And how might that change the character over time? Okay? A lot of us worry about that as parents, right? When we think about whether we should be giving our kids, financial incentives to do well in their report card. Right? And how that might affect their, hopefully, sort of natural joy for learning. Right? I had a very much a personal experience with that. When my son started high school a few years back, it seemed to me that he was a lot more interested in developing his hockey skills than his academic skills. So I had some ambivalence about it, but I ended up giving him a financial incentive to do better, on his report card, and I think it actually did help. I think I did see improvement. Okay, but the next year, came back to me and said, "Well, am I getting money for doing well again?" All right. So I grimaced a bit, and I said, "Okay, all right, same deal." And he looked at me without blinking and said, "What about inflation?" So what are we sort of getting ourselves into? Okay, how long are we going to have to maintain financial incentives? Okay, to see some quality improvement? What happens if we withdraw the financial incentives? Or are we going to have to continue to increase financial incentives to get higher levels of quality? So one study that we did in the Veterans Health Administration, where they actually provided quality incentives for a variety of performance measures and then withdrew them. Okay? They provided them for a period of time and then they withdrew them. Okay? And as you can see, during the incentive period, you do see improvement on a lot of these quality measures. But then you go to the phase where they withdrew them. And what you see is that for the most part, improvement stops. And in some cases, even decreases. And there was another study that was just reported in the literature that shows the same thing, only indicated even more conclusively that for the most part, performance just drops. Okay? In some cases, dropping right back to where you were before. Okay? So, again, what happens when we start monetizing quality of care? What are we sort of getting ourselves into? Okay? How long do we need to maintain incentives? And we have to continue to increase them. Okay? How much do we really understand about this? Other barriers, infrastructure and training. You know, we're asking physicians to achieve these performance targets. A lot of them don't have electronic health records. They don't have disease registries. Okay? That's improved a lot in the last couple of years, but a lot of providers lack important information technology. Okay? Also skills. If providers are being asked to ensure that their patients receive certain tests and screens that they don't have direct control over, they need to be communicating with their patients and finding ways to motivate them to do this. How well trained are many providers to do this? Okay? So infrastructure and training. A new study just came out that said that where you really see gains in quality improvement is where you combine pay for performance with state-of-the-art information technology. All right? And another barrier is simply our knowledge for designing programs. Okay, it may be insufficient. We just lack a lot of information about who we should be incentivizing, individual physicians, the practice organizations, hospitals, accountable care organizations. We really don't know exactly who should be the target, the unit of accountability. Similarly, how should we structure incentives and these performance targets? There's a lot of information that we still really need in order to be in a position to design these programs in the most effective way. I also mentioned unintended consequences. Should we be frightened of that? Well, there are some concerns that, for example, providers may avoid patients, okay, who are sicker, who they think will potentially hurt their ability to achieve these performance targets. So will they be avoiding sicker patients or patients who they think won't comply with their request to undergo certain tests and screens? Okay. Another is teaching to the test. Will providers only focus their time and energy on these explicit performance targets and ignore other potentially important activities that simply are not codified in a performance measure? Right? That raises certain concerns. Okay? I don't think there's much evidence on this point right now, okay? But this certainly raises concerns to people. Okay? Sort of raises our anxiety levels a bit. Okay? So to wrap up, what does the future hold? What does the future hold? Well, I don't think there's any turning back. All right? I don't think we're going back to fee-for-service. I think there may be some things to be anxious about, or perhaps the better word for today is scared. Okay? But truthfully, you know, obviously we're going into some territory here that we don't understand all that well. Okay? We're walking into the dark. Okay? But I would also say we're walking into the dark with blindfolds on, because we've been in the dark for a very long time. We've been providing healthcare services, okay, without having any clear understanding of how they're linked to quality of care. Okay? We continue to see healthcare costs soar. We know now there's excellent evidence that quality of care in this country is suboptimal. Okay? So we may be walking into the dark, okay, but I would argue that we're walking into the dark with blindfolds anyway. So I don't think there's really all that much to be scared of. All right? I think we need more experimentation. Okay, we need to continue to learn and try to find better ways to link payment to quality. We need to be keeping people healthier. Keeping people healthier. That's what we need to be focusing on. How do we create payment incentives that will keep people healthier. And, finally, I think we need very strong cooperation between purchasers, health plans, government agencies, and providers. I think for the most part we can say that relationships between providers and purchasers are often not particularly positive, very often adversarial. I think Blue Cross Blue Shield of Massachusetts has really done an excellent job with the alternative quality contract to really promote cooperation between a health plan and a provider group, and you'll hear more about that. So at this point, let me turn it over to Sarah. Thank you.